What if I told you that the future of treating complex pelvic floor issues, and we're talking everything from severe sexual dysfunction to stress urinary incontinence, doesn't actually involve surgery?
Right. Or physical therapy, even.
Yeah, exactly. Or even those, thick artificial tissue fillers. What if the ultimate fix was just sending a microscopic text message directly to your cells, giving them the exact blueprints to heal themselves?
It sounds like science fiction, honestly.
It really does. But you've provided us with a truly fascinating stack of medical research today, and we are going to explore a massive paradigm shift in regenerative medicine.
We really are.
So the core question we are exploring in this deep dive is, can we inject nanoscale biological messengers, these things called exosomes, directly into a specific layer of pelvic tissue known as Halban's fascia to target the periurethral plexus and the G-spot zone?
It is a profound question. And to truly grasp the answer, well, we have to recognize what a leap this is. Well, for decades, medicine has relied on a very mechanical, structural mindset. If a joint wears out, we replace it.
Right, hardware.
Exactly. If tissue loses volume, we inject a space-taking gel. It is basically structural engineering. But with these sources, we are moving entirely away from simple structural fixes and venturing into the realm of true cellular reprogramming.
Okay, let's unpack this, because reading through these sources, it is genuinely thrilling to see how modern science is finally demystifying the pelvic floor.
It is long overdue.
Yeah, it has always been treated a bit like a black box, right?
It really has. And the anterior vaginal wall specifically is arguably one of the most historically debated regions in human anatomy.
Oh, absolutely.
So before we can even talk about how we treat it with exosomes, we first have to map exactly what we are treating. We have to understand the territory.
Which seems to be easier said than done. Looking at the systematic reviews and the data you brought, the medical community has literally spent decades arguing over a pretty basic question.
Whether the G-spot even exists as a distinct organ.
Right. Is it a distinct anatomical organ, or is it just a broader physiological region?
Exactly. And the debate is fascinating. On one side, you have researchers like Ostrozensky. In 2012, he conducted a really highly publicized cadaver dissection study and concluded that it's a very distinct physical structure.
Like an actual defined
Yes. He documented finding a specific grape-like neurovascular sac.
A sac.
Yeah, a tiny sac. He even measured it was 8.1 by 3.6 millimeters, located exactly 16.5 millimeters from the urethral meatus on the dorsal perineal membrane.
Wait. An actual grape-sized sac? That sounds incredibly
That's
specific.
extremely specific, yeah.
Almost like finding a tiny hidden organ that everyone else just somehow missed.
It does sound like that, which is exactly why it caused such a stir in the medical community.
Yeah.
But then, you have to contrast that with the broader consensus, like Levin's 2003 concept.
Right, the erogenous complex.
Yes. Levin looked at the exact same region, but described it as the anterior wall erogenous complex.
Mhm.
This perspective argues that you aren't looking for a single isolated sac.
Okay.
Instead, it's an entire interconnected network.
Meaning it's not a single point you can just, circle with a marker.
Precisely. It includes the urethra, the clitoral roots, and Skene's glands.
And Skene's glands are, they're the ones that are like the prostate, right?
Exactly. They are present in about 90% of women and function essentially as the female equivalent of the prostate. But crucially, this whole complex includes a structure called Halban's fascia.
Let me stop you right there, because Halban's fascia keeps coming up in the research. And I am picturing fascia like the tough white gristle you see on a piece of steak.
Right, like inert connective tissue.
Yeah, exactly, just dead tissue. But the research implies this area is highly active.
That is a great distinction to make. You need to throw away the idea of inert gristle. Think of Halban's fascia as a highly dynamic vascular sponge.
A sponge. Okay.
It is a fibroelastic sheet located right between the trigone of the bladder and the anterior vaginal wall. Yes, it is rich in collagen for support, but it also has a massive blood supply, and it is packed with Krauss bodies.
Krauss bodies, what are those?
They are pseudocorpuscular nerve endings, basically highly specialized sensory receptors.
Oh, I see.
When this fascial plane is stimulated, the blood vessels rapidly engorge, the entire tissue becomes vasocongested, and it creates a highly sensitive physiological response.
Wow.
Furthermore, your sources map out how this area is intimately connected to the vesicovaginal fascia, the VVF, and the neural compartment. We see anterior nerve projections from the inferior hypogastric plexus passing right through this extraperitoneal plane toward the urinary bladder.
So it is just a superhighway.
It is an absolute superhighway of nerves and blood flow.
Okay, but I have to push back here for a second. You just described a highly complex, interconnected web of nerves, blood vessels, and spongy tissue. And you also mentioned that researchers still debate whether a specific organ even exists there. So if a clinician is going in with a needle, well, aren't they just flying blind?
That is a very logical concern.
Right. How do you reliably inject a therapy into a debated complex?
Well, what's fascinating here is how the functional surgical anatomy actually guides the clinician, regardless of the academic debate.
Okay, how so?
The pelvic floor isn't just an amorphous soup of tissue. It is highly organized by distinct fascial layers. You have the umbilicovesical fascia, the urogenital hypogastric fascia. These layers act like natural biological envelopes.
Oh, I see. So they aren't aiming for a tiny coordinate on an XY axis. They are aiming for the envelope itself.
Exactly. The clinician isn't trying to hit a pinpoint dot. They are targeting that specific neurovascular web contained within a known fascial plane.
Just get it in the envelope.
Right. They just need to deliver the treatment into the envelope of Halban's fascia, and the tissue's natural architecture does the rest.
So if Halban's fascia is essentially a dense, highly vascularized sponge, it makes sense that you can't just forcefully inject a massive volume of thick synthetic gel in there without causing problems.
Absolutely not. It would be disruptive.
Right. You need something microscopic that can actually navigate that delicate web,
Mm-hmm.
which leads us directly to the what.
Yes, the exosomes.
Exactly. What exactly is being delivered into this envelope?
This is where we shift to the exosomes. They are the stars of this regenerative movement. By definition, exosomes are extremely small extracellular vesicles. We are talking 30 to 150 nanometers in diameter.
Which is almost impossibly small.
It is. To put it in perspective, they are much, much smaller than other cellular byproducts, like the larger microvesicles or apoptotic bodies, which are really just fragments of dead and dying cells.
So where do they come from?
Depending on the specific treatment protocol and your sources, these clinical exosomes are usually derived from either the patient's own platelet-rich plasma, called PLT-exos, or from adipose-derived mesenchymal stem cells, the ADMSCs.
Okay, but just to be totally clear for the listener, they're not cells themselves, right? We aren't injecting living stem cells into this tissue.
Correct, and that is a vital distinction to make. What we are discussing is cell-free paracrine signaling.
Cell-free.
Right. When a clinician injects these exosomes, they are not transferring living cells or donor DNA into the patient. Instead, imagine an exosome as a microscopic, tough little bubble.
A bubble.
Yeah, the outer shell is a lipid bilayer.
And what's inside the bubble?
Cargo. Specifically, highly specialized messenger RNAs and microRNAs. That tough lipid outer shell protects the genetic cargo from being destroyed by enzymes in the patient's tissue before it can deliver its message.
So if injecting whole stem cells is like hiring an entire construction crew to come fix a broken house, injecting exosomes is like texting the blueprints and the repair instructions directly to the local construction workers who already live there.
Telling them to wake up and do the work.
Exactly.
That is the perfect analogy. You are just delivering the instructions, and the biological effects of those instructions are profound.
Tell me about the effects.
Well, the sources detail 3 major mechanisms of action once those instructions are received by the local cells in Halban's fascia. First, the exosomes downregulate enzymes known as matrix metalloproteinases,
Okay.
specifically MMP1 and MMP3.
And what do those enzymes normally do? Why do we want to downregulate them?
Because they break down the extracellular matrix. They are the enzymes responsible for tissue degradation and aging.
Oh, wow.
So step 1 of the exosome message is basically stop the wrecking ball, halt the breakdown of the existing tissue.
Stop the damage first. That makes sense. What's step 2?
Step 2 involves the immune system. Exosomes induce what is called macrophage polarization.
Macrophages being the white blood cells.
Right. The exosome cargo literally instructs these macrophages to shift from a pro-inflammatory M1 phenotype, which causes chronic swelling, heat, and irritation, to a reparative M2 phenotype.
So it flips a switch from fight the infection to rebuild the neighborhood. It calms the whole environment down.
Exactly. It is a complete shift in local immune response. And once the environment is calm, Step 3 begins.
The rebuilding phase.
Yes. The local cells are instructed to release vital growth factors, specifically VEGF and BFGF. These are the chemical signals that actively restore the microvascular capillary networks.
So it makes new blood vessels.
It triggers the body to sprout new, healthy blood vessels, restoring blood flow to that previously damaged or aged tissue.
Okay, I have a logistical question, though. If these exosomes are just microscopic bubbles of fat-carrying genetic text messages, well, how do labs harvest them without popping the bubbles?
That is a great point.
Because if the lipid bilayer breaks, the enzymes in the body will just eat the mRNA, and the text message never gets delivered.
Right, and this raises an important question about clinical quality control. The research heavily emphasizes this. Because they are so fragile, you can't just toss the source material into a standard medical centrifuge and spin it at high speeds.
Right, because traditional centrifuges would just crush them. It would be like putting delicate water balloons in a blender.
Precisely. It would destroy the product. So to get clinical-grade exosomes, labs use a completely different technique called tangential flow filtration, or TFF.
Tangential flow filtration.
Yes. Instead of crushing them with raw centrifugal force, TFF gently sweeps the fluid sideways across a microscopic filter. It preserves the integrity of that delicate lipid membrane.
That is really clever. And how do they prove they actually captured exosomes and not just random cellular debris?
They verify the purity by looking for specific tetraspanin cell surface markers, things like CD63, CD81, and CD9.
So those are essentially just the shipping labels on the outside of a bubble proving it's the right package.
Exactly. It guarantees identity. And finally, they use nanoparticle tracking analysis to guarantee the concentration. We aren't talking about a few thousand vesicles here.
How many are we talking?
A clinical dose requires a concentration of 10 to the 10th power or 10 to the 11th power of these exosomes per milliliter.
Or billions upon billions of text messages. So now we have our pristine concentrated blueprints. And we have our anatomical address, the envelope of Halban's fascia.
We do.
How does the needle actually get the blueprint to the address safely? Because injecting anything into an area packed with sensory nerves and a superhighway of blood vessels sounds intensely delicate.
It is, which is why the sources detail a very precise, minimally invasive clinical protocol. The standard administration uses a 32-gauge needle.
Oh, that is tiny.
That is an incredibly fine needle, often used in precision facial aesthetics, and the syringe tip is only 4 millimeters long.
Just 4 millimeters. Why so short?
Because depth is everything here. A retrospective review in your data outlines the technique the clinician injects 2 cc of the exosome solution, point by point, into the G-spot area.
The distal third of the anterior vaginal wall, right?
Exactly, as well as the clitoral glands and the periurethral area. But they have to be exact. If the needle is too short and goes too shallow, the fluid just ends up in the superficial mucosal epithelium where it doesn't do much good.
And if they go too deep?
They risk hitting the deep periurethral smooth muscle. The target is specifically that submucosal layer, Halban's fascia.
So how do they ensure they hit it?
Clinicians utilize a 2-finger transvaginal check during the injection. They're using tactile feedback, verifying by touch that the fluid bolus is being deposited perfectly into that spongy fascial envelope.
I really want to contrast this with the older structural treatments we talked about at the beginning.
Right.
For years, the buzzy treatment in this area was the G-shot.
Ah, yes.
Which was just injecting hyaluronic acid.
Yes, HA fillers have been the standard for a long time, but the mechanism is entirely different. Hyaluronic acid relies purely on mechanical volume.
It's a bulking agent.
Right. It is a thick gel designed to physically bulk up the tissue, creating counterpressure during intercourse.
Basically like shoving a rolled-up rug under a carpet to artificially create a bump. It just takes up space.
That's a very accurate, if blunt, way to visualize it, but because it relies on structural bulking, it comes with mechanical risks.
Like what?
Well, there is the risk of mechanical extrusion, where the physical pressure of the body literally pushes the thick gel out of place.
No, wow.
There is also a serious risk of vascular occlusion, where that gel accidentally blocks a blood vessel, leading to tissue death.
That sounds dangerous.
It can be. And if something goes wrong, you have to rush in with an emergency injection of an enzyme called hyaluronidase to melt the filler away.
Yikes. So exosomes bypass all of that because they are just a liquid carrying a message, not a structural gel.
Exactly. Exosomes provide biological tissue remodeling, not structural bulking. There is no physical mass to migrate and no thick gel to block an artery.
So what does this all mean for the patient? We've talked about the anatomy, the nanotech, and the needle. But after those billions of exosomes are deposited into Halban's fascia, what is the actual physical result for the person receiving the treatment?
The clinical outcomes drawn from your sources are remarkable. Let's look at sexual dysfunction first.
Right.
The research highlights a study of 60 patients who received 3 exosome treatments spaced 4 weeks apart. The results showed highly significant, quantifiable improvements in their female sexual function index, or FSFI, scores.
And the sources break down why that score improves, right? I mean, it isn't just a subjective placebo effect.
No, not at all.
The exosomes are doing measurable physiological work. They enhance localized clitoral neurovascular engorgement, meaning better blood flow.
Yes.
They decrease arousal latency, so it literally takes less time for the body's nerve endings to physically respond to stimulation.
And beyond the nerves and blood vessels, they actively change the cellular output of the tissue. The exosomes stimulate the local fibroblasts in the vaginal wall to express endogenous hyaluronic acid synthase.
Wait. Specifically HS2, right?
Yes, HEs.
So instead of injecting artificial hyaluronic acid filler, the text message tells the patient's own body to start manufacturing its own natural hyaluronic acid again.
Exactly. The body restores its own natural volume and lubrication. Furthermore, as tissues age or suffer trauma, like from childbirth, the microscopic seals between the cells break down.
The cell barriers.
Yes, and exosomes help restore the integrity of tight junction proteins.
Like repairing the mortar between the bricks of a wall.
Perfectly said. Specifically, they upregulate proteins called claudin-1 and occludin. This restores a healthy, strong vaginal mucosal barrier, stopping irritation and chronic dryness at the cellular level.
That is incredible.
It is. But if we connect this to the bigger picture, we have to realize that this highly active neurovascular web doesn't just exist for sexual pleasure.
Right.
There is a massive crossover here with a condition that affects millions of women globally, stress urinary incontinence, or SUI.
Here's where it gets really interesting, because the exact same anatomical hammock we've been talking about, the anterior vaginal wall, the periurethral plexus, is the primary support structure for the bladder.
It is. When a patient experiences stress urinary incontinence, meaning they leak urine when they cough, laugh, or sneeze, it happens because that fascial hammock and the underlying muscle have weakened.
It just can't hold the pressure.
Right. It can no longer pinch the urethra shut under pressure.
And traditionally, you treat that with the physical sling surgery or maybe pelvic floor exercises.
Usually, yes.
But the sources indicate that exosome therapy can address the root cellular cause of that linkage. They literally promote the regeneration of the pubococcygeus muscle.
They do. The exosomes activate muscle satellite cells. You
Yeah.
can think of satellite cells as dormant stem cells that live inside the muscle tissue, just waiting for a signal to wake up and repair damage.
And the exosomes are the signal.
Yes. The exosomes provide that signal by activating specific cellular communication pathways, the ROS-ERK and WANT beta-catenin pathways.
So it's like sending a bugle call to the reserve troops sleeping in the barracks, telling them to get up, divide, and build new muscle fibers.
That is exactly what the ROS-ERK and WANT beta-catenin pathways do. They trigger cellular division and differentiation, but rebuilding the muscle is only half the equation for incontinence.
What's the other half?
You also need the nerve signal to tell that new muscle to squeeze at the right time.
Oh, right. If the electrical wire is cut, it doesn't matter how strong the muscle is.
Exactly. And this is perhaps the most revolutionary finding in the research. The sources highlight that exosomes derived specifically from Schwann cells, which are the cells that support our nervous system, can actively protect and repair damaged pudendal nerve fibers.
Wow. So they are healing the frayed electrical wiring too.
Yes, the nerves themselves.
A single, targeted therapy injected right into the envelope of Halban's fascia could simultaneously reverse severe sexual dysfunction and treat urinary leakage purely by regenerating the underlying muscle, the fascial sponge, and the neural wiring.
It truly represents a fundamental shift in how we view the human body's capacity to heal itself. We aren't patching the leaky pipe anymore.
We're fixing the plumbing at the source.
Exactly. We are providing the tissue with the precise instructions it needs to restore its own integrity.
Okay, let's take a breath and recap the journey we've just been on. We started by navigating the surprisingly debated, complex anatomy of the anterior vaginal wall, discovering the highly vascular envelope of Halban's fascia.
A fascinating area.
Truly. We explored the cutting-edge science of exosomes, these 30 to 150 nanometer lipid bubbles that act like encrypted blueprints for cellular repair.
Right.
We detail the precise clinical mechanics, from tangential flow filtration to using a tiny 4 mm needle to ensure those blueprints land exactly in the submucosal layer without the risks of thick artificial fillers.
Avoiding all those extrusion risks.
Yeah. And finally, we uncovered how this cellular text message is revolutionizing clinical outcomes, treating both sexual dysfunction and stress urinary incontinence by actually regenerating muscle, nerve, and mucosal tissue from the inside out.
The implication for anyone listening to this is truly staggering. Whether you are actively researching regenerative medicine, whether you are looking for modern solutions for a specific pelvic floor condition, or you are just deeply fascinated by the future of healthcare, you are witnessing the boundary line between managing a symptom and actually regenerating human tissue.
And I want to leave you with a final, slightly provocative thought inspired by the incredible science in these sources. We've seen that isolating exosomes can successfully reprogram localized mucosal aging and repair nerve damage right there in the pelvic floor.
We have.
But what if we took this concept to its absolute limit? If scientists can map the secretome, the perfect, customized cocktail of growth factors and microRNAs of a spectacularly healthy, useful patient, well, could we eventually use that isolated cocktail to reverse biological aging in any localized mucosal tissue in the human body?
That is a massive idea.
Imagine an a la carte form of cellular time travel where you just text the exact blueprint of youth to whatever tissue in your body needs it most.
It completely rewrites the rules of biological aging.
It really does. It turns out the human body isn't a rigid mechanical machine just waiting to break down. It's an incredibly dynamic, living system. It just needs the right set of instructions.